I'm really excited to be joining you this morning and to think a little bit about ADHD in clinical practice. I think the way Amber had suggested is that we go through a little bit of the theory and we leave the talking for after. Would that work better? So if you can hold on to your questions, that would be great. What Amber didn't tell you, even though she says it's a good place to visit, is how disorganized we are. So we ended up with sort of triple bookings today. So I'm actually quite chuffed and relieved to be here, not sitting in the office. Just a few disclaimers. Firstly, I have a reputation of being one of the most conservative prescribers in Joburg. That doesn't impact on my prescription of medications, but just to hold that in mind. Secondly, I'm a parent of a 6-year-old with ADHD. So a lot of what I bring to you comes not only from clinical experience, but also from personal experience. And then lastly, this little insignia, which will change, is the insignia of the South African Association of Child and Adolescent Psychiatry, of which I'm currently president, so that's the only accolade I'll give you. But we've also been asked that every time we speak that we just acknowledge the fact that we're members of the association, and just to invite you, if you have any queries or any issues around child and adolescent psychiatry, the SA ACAPAP site is a good place to go and have a look at this. So these are a couple of the issues that I'd like to outline, and we'll sort of spend a little bit of time around here, because this is the real issue in clinical practice. So what we know, and what I'm sure I don't need to tell you, is that really ADHD is one of the most common, if not the most common, neurobehavioral disorder in childhood. It has a significant impact. And I have to admit, before I left this morning, I was sitting nagging my 6-year-old to please have breakfast while he upped and he downed and he upped and he downed, and I fiddled with my slides. So I hope that the slides are all going to be in order. So this is a statement from the American Pediatric Association. If one looks at the rates of prevalence, I suppose it's difficult to interpret the data. And there's a whole sort of controversy around, well, ADHD is actually just a made-up condition. It's made up by the Americans. It's made up by companies like Novartis, just so that we can give medication, because the psychiatrists have a vested interest in medicating children. The reality is, and we'll discuss a little bit more about it later, is this has been around long before Novartis existed, and long before any other drug company existed, and even long before psychiatry as a discipline in the clinical arena existed. What we think is that about 5% of kids, sometimes pushing upwards, and you can see very interesting in some countries, the rates are quite different from others, but somewhere between 5 and 8% of children, school-going children, have features of ADHD. It seems not to persist in adolescence if one looks at the figures, but I think what we'll do is when we chat through the different eras, age ranges, we'll see how it looks a little bit different. And really what's interesting is that it persists across cultural domains, it persists across racial domains, it persists and it exists across socio-economic differences. And I've had the privilege of working for a long time in state sector, and now more recently in the private sector. And so I've seen this condition in many, many settings. And it looks very similar in many, many settings. The impact, of course, is different, and who brings and why they bring and how they bring is possibly different. This graph on the left comes from ACAPAP, which is the International Association of Child and Adolescent Psychiatry figures, and this just shows you a little bit about the sex ratios, boys to girls. And we see, as you know, that boys are far more commonly than girls, and somewhere around 4-5 to 1. Something weird going on in Austria, I don't know, and something weird going on but you can see mostly that the line is up there. So it's a common condition. And most teachers, most parents, most families are going to have somebody who manifests with this problem. Here, just again, to give some idea about the broadness or the spectrum of prevalence throughout the world, you see again that really the numbers sit around between 5 and 6. Again, interestingly, something weird going on in South America. In Africa, they say a lot, but you can see these are issues which really relate to the fact that there's not a lot of studies. Okay, so as I'd said earlier, it's not a new concept, and there's old pictures going back to the 1800s of disturbed young people. But this famous paper, which was, I think, written by somebody by the surname of Still, was published at the beginning of the last century and said, well, these young folks have a deficit of moral control. And there's real problems with impulse, inhibition, and it must be because they're amoral people. And I think in some respects these early papers still haunt us because of the stigma that we still see around ADHD. Then it became known as minimal brain dysfunction because they discovered that some people seem to have brain lesions associated. And then we've seen the changes in nomenclature over the years. ADDH, hyperkinetic syndrome, and in the ICD-10 it's still referred to as hyperkinetic syndrome. And then of course we're now onto DSM-5, and we'll chat a little bit about DSM-5 a little bit later. So it's not a new concept. Certainly not made up by the Americans, and certainly not made up by companies such as yourselves. So what I wanted to just touch on here, and this is for me a day-to-day kind of issue. This is what I just sit and counsel parents about all day, is just to acknowledge that there are some controversies here. And this is taken from an ethical paper, which really just outlined that there are sort of 7 key areas where we get stuck in thinking and talking about ADHD, and in people accepting management and accepting medication and accepting treatment for ADHD. I mean, the reality is, in psychiatry has this as its sort of cross to bear, is that we talk about heterogeneous symptoms. So when you go into the realm of cardiology, if you've got mitral stenosis, you've got a murmur in the chest, you've got a particular pulse, you've got a particular view on the echo, there's no two ways about it. It's there. It's grade 1, 2, 3, or 4, but it's there. But in psychiatry, and when it comes to emotions and behavior and thinking, we've got what we call a heterogeneous set of symptoms. You've got some clear-cut ADHD. And what they always used to say to us at med school, the ones that the postman can diagnose. No one's going to dispute that. But then you've got a lot of kids, which this paper calls, who sit in the zone of ambiguity, that actually don't quite fit. Okay. When we talk about symptoms and impairments being dimensional, it means that they're along a developmental and dimensional perspective, that they don't fit into a particular category. DSM-5 is a categorical set of symptoms. It means you must tick the boxes. But the reality is, when we tick those boxes, it doesn't always fit. I mean, if you look at that on the checklists, how organized are they? Well, how organized is a 5-year-old? You know, how disorganized is a 5-year-old? Do they lose their stuff? Well, does a 7-year-old lose their stuff? So the dimensional understanding of the condition is really important, and acknowledging that zone of ambiguity is important. There are other variables: parenting styles, parenting expectations. What sort of narrative is used to explain the behavior? How is the behavior interpreted in the classroom? What's one teacher's sort of ADHD is another teacher's indigo child expression, exploring the world. So the variables that come in make making the diagnosis difficult, but also make decisions around treatment difficult. And then, of course, this goes back again, competing views. What is the goal of psychiatry? What is the goal of parenting? What do we do about those kids in the middle? And the kids in the middle, there are quite a lot of them. In this article, I love this quote: "Because nature has not written a bright line between the impaired and the unimpaired child, it is the responsibility of humans to choose who gets the diagnosis." And that doesn't mean that the diagnosis is not significant. And what was interesting for me in this paper is to say, well, people will say, but there's no test. Do your dopamine levels, do your SPECT scans, show me on the brain, show me on the EEG. Well, there's no test. But there's another very common condition that doesn't have a test. Does anyone know what it is? A brain condition, very serious brain condition. The epilepsy, we've got a test, but migraine. There's no test for migraine. Migraine is a very common, very debilitating condition. So we mustn't let the fact that we haven't got clear boxes to put this in detract from the fact that this can be a very significant, very impairing condition. Truth of the matter is, treatment is complicated, and treatment is not, there's no silver bullet. Well, there is for some kids, but for many, there's not. And the value systems will impact on the choices that parents want to make, and truly informed decision making actually requires that we give the parents the information. And I find this is partly the difference between my practice in private versus state, whereas in the years where I worked at Barra or Charlotte Macheke, oftentimes parents would just be relieved to have some sort of fix because the resources at their disposal were so limited. Whereas the private parent will come in, they've read this, they heard this in the parking lot, they've Googled that, and so they need to understand the intricacies of what going on treatment means. What going on treatment means for the long term, what going on treatment means for the now, and of course, everyone knows that Ritalin kills children, you know. I mean, this is the kind of stuff that comes in. So I use a third of my consultation time, which is 90 minutes, spending time just really discussing and helping parents and children to make this decision. What's interesting is that for young children, we always assent. So we get them to agree to take the medication. We don't get them to consent to take the medication. And often parents don't want to include children in the discussion, but it's really useful to include children in the discussion because they will tell you what the experience is like in class, how it feels not to be finishing, how it feels to be staying in a break to get your work done. And once they've had the medication, they will even say things like, I finally showed up in class, okay? So they will actually help you to make the decision, where the parents sometimes have their own issues to deal with. I'm sticking with the so-called controversies, and I'm only really touching on a little bit about what we know about the biology, because at the end of the day, what I often use in discussion with parents is to say, well, this is a biological condition. Your child has co-occurring asthma. He or she has very reactive pipes. And would you let your child carry on wheezing? Okay. Would you let your child carry on wheezing? What we know is associated with the advent from a biological perspective of ADHD are these conditions. Very, very common, almost without fail. Premature birth, a stint in neonatal ICU, almost without fail. Perinatal birth complications and heritability. But then, of course, you've got dad who says, but I was just like this and I'm fine. I'm fine. I've got no problem. So heritability is very high. We haven't got genetic markers as yet. There's some genetic markers that seem to make more sense. And at the end of the day, part of it is it's a brain disorder, okay? We've got delays in cortical maturation in some areas. We've got deficits in executive functioning and inhibitory control, and we'll discuss what those mean in the clinical setting. But sometimes if you can help parents understand, well, this is no one's fault. This just is what it is, and this is a brain condition in the same way as I've got lousy eyes, and in the same way as the other child has got asthma. This is something we have to manage. All right. So, what is the clinical presentation? And bearing in mind that the clinical presentation is as varied as there are children. And it really does vary according to developmental age. The condition itself, and thinking about the possibility of the condition existing, needs to be red flagged when you see something different than what you would expect at that particular stage. Okay? Symptoms may and actually must manifest in more than one setting. This, I find, makes for quite a lot of diagnostic complication, because you'll get a teacher who will send you a checklist and everything's ticked, big red marks, and the parents will come and say, but he's fine. There's nothing wrong. He's a boisterous child. So it must arise in more than one setting, which means that one's assessment of children in this situation needs to be quite broad. And you can see here with this picture is that really it's not just about the lack of concentration. It's also about children being perceived as being naughty, children being perceived as being miserable, children being perceived as just not listening. Okay, so these are the DSM criteria, and what I hope to do through this is just talk you through how this might look on a day-to-day basis. How might the child be referred? What are the issues that are showing up on a day-to-day basis? Usually, it is a teacher who suggests a referral when it comes to the inattention syndromes. Usually because we're not completing work, the work pace is slow, we're distracted, we're not listening, we're dear mekaar, we're disorganized, things are all over the place. And so the patient will come and say, well, we've got concentration difficulties. My job is to then say, well, okay, so we've got an 8-year-old here. The list of potential causes of concentration difficulties is as long as my arm. Concentration for me is what fever is for the GP. You know, the GP, there's 1,000 causes of fever. Is this ADHD? How do I work this out? Okay. And so yes, we go through the checklist, and I'll go through the list, the criteria in a little bit more detail. Are people comfortable that you can read this? Okay. I'm getting old, so I need to read this. Okay. So, and what I will try and do, let's just see, yeah. So this will, I'll focus on the developmental view of things in a minute. So attention to detail. So it really is about the quality of work that the child presents, okay? The quality of input that he or she gives in regards to we're building something and we're playing. Following instructions, failing to complete a task. So typically parents would say, I send him off to go and get dressed, and I come back 20 minutes later and we've got one sock on. And we're sitting on the floor with the Lego, okay? Or I send him off to go and find his school bag, and we come back and we discover, oh, the school bag's still at school. We left it yesterday, okay? In adolescence, how does this look? Well, it's just about sort of being disconnected, not present, floating around, drifting around, being on my phone. So often parents will come and say, well, you know, the problem here is not the child, the problem is the phone. We're going to take away the phone. So all of these sort of things kind of manifest in developmentally different ways, but typically not finishing at school, marks start to go down, not getting homework done, not bringing things home for parents to sign, getting lots of detentions, getting lots of demerits. This sort of stuff shows up on a day-to-day basis. At home, it's less of an issue, because if you drift and you float and you go and potter here and you go and potter there, and they say, but he doesn't have concentration problem because he can sit in front of the TV for 3 hours solid. And he can sit in front of the Xbox and play whatever for 6 hours, and he's brilliant. There's no concentration problems because he's not distractible, okay? And really, that's one of the hardest things to sort of navigate with parents, is to say, well, it can be task specific. You know, it can be that attention, if something particularly grabs a child, that task can be done to the exclusion of anything else. So they'll say, well, he's brilliant. He does age 16 Legos, and he's only 7. He doesn't have ADHD. Forgetfulness, I find, is a difficult symptom to elicit in kids. We're forgetful, you know, those of us in the 4th and 5th and other decades. So it's a difficult symptom to elicit, but oftentimes it will be like, oh yeah, we were supposed to do this, I forgot. Okay. Avoidance. And this is where sometimes children will be referred with concerns that they're actually ODD, oppositional defiant. They're avoidant, they're refusing to do stuff. Or they're intellectually impaired because they refuse to do stuff. Or they're actually just bloody difficult because they won't do their homework. So always asking around, what's the engagement like in the class? How do they manage homework? How long does homework take? Who does homework? How long should it take? And when we're 20 minutes in grade 2, and we're taking 90 minutes, because why? Because we drift, and then we go and get some water, and then we come back, and then we just have to play with the dog, and then we come back. So avoidance tactics are quite significant. There's a feeling, and many parents start with a listening test, that the child doesn't listen, okay? That you can talk and talk and talk and talk, and the child doesn't listen. And I think there's a selective off-button switch that ADHD kids have. But the reality also is that many of these children have auditory processing difficulties. So actually their interpretation of language or something that's given to them doesn't always make sense. And they're not always sure that how to respond, and they would never acknowledge that. But listening, huge source of frustration. Getting organized, very difficult to understand in younger kids, and often what parents do, and I always ask them, why? Who packs the bag? Why? What if you didn't pack the bag? Who puts the stuff together at the end of the day? What happens if you didn't do that? Because we'll get reports from teachers saying, his stuff, he needs 2 desks. He can't share a desk with anyone else. There's stuff on the floor, there's stuff all around, and then he, on top of that, can't stay in his seat. So getting organized is difficult. Easier to interrogate in older kids, and the sort of from about 10, 12, that sort of executive functioning of planning, organizing, getting things on track starts to come in, and then you can interrogate this. But naturally, for a person who has ADHD, this thing doesn't happen, okay? And I send a lot of university students and a lot of high school students to the occupational therapist to be taught how to put things in files, how to plan, how to write a diary. And so always questioning and interrogating around the homework diary, what happens with the homework diary, those kinds of things. And then things get lost. So you can, you know, you ask, where's the yamuka? How many times have you replaced pens, jerseys, shoes? I've had many, many children rock up to consultation barefoot. Big children, 15-year-old, where's your shoes? Oh, I don't know. We had sports, and then they were gone, and that was it. You know, so, and these are things. And if you think about all of this stuff, and you think about a busy family home, you can think about parental frustration. You know, you can think about parental frustration. Go and brush your teeth 27 times, okay? And then eventually, and you can think about relational frustration. Eventually you say, but does everything have to be a negotiation? What's a negotiation? You know, but everything, and this is conversation with my son, you know, does everything need to? But it does, because then we're playing with the airplanes, and, you know, and so you can see how parents might present themselves with a lot of frustration, and also how this kind of stuff, which feels quite innocuous, actually can impact quite significantly on parent-child relationships. Okay. The hyperactivity for me is a bit more of a no-brainer, because most people associate, oh, I can't take this off actually. Most people associate ADHD with hyperactivity. And most people will say to you, well, it can't be ADHD because he's not hyperactive. So we need to be cognizant of the different subtypes. And the hyperactivity is easy to see, and the hyperactivity starts very young. What's hard to distinguish, particularly in young children around the hyperactivity, is what one would expect. One expects kids to run around, one expects kids to climb, one expects them to do all of this, and what's normal and what's not, and what's abnormal. Okay, so the hyperactive kids struggle to sit still. They run, they climb, they're on the roof, they're in the trees, they're up there. I remember a colleague saying her son was little, he just started walking, and she said 1 minute she was doing something, next minute she checks, there's the 1-year-old, 1.5-year-old climbing up the burglar bars. And that's a kind of ADHD behavior. They're often seen like they're on the go, the sort of Duracell sign. They're often noisy, and I always ask parents, do you know if he's around? Is he the kind of kid that you know is around? Or is he the kind of kid who can potter off, go and do his own thing? Okay. And they like to talk, and they talk, and they talk, and they talk, and they talk. And they talk in the classroom, and they talk with their mates, and they distract their mates. And, you know, there is something absolutely delightful about children who are this kind of buoyant and energetic, but obviously it can have quite a disruptive influence in the class. And so teachers will often refer because of disruption in the classroom. I'll go through, it's difficult to know how to piece this all together, but I'll go through the differential diagnosis with you, and hopefully as we do that, you'll get I'll unpack the clinical presentation a little bit more. Okay, so they're busy. These are typically boys. These are often more likely to be girls, but maybe boys as well. So these are typically boys, and these are the kids where it's a bit of a no-brainer. When I worked at Baragwanath, this aspect of behavior and this aspect of behavior caused Dr. Helen Clark to actually start an under 6 ADHD clinic, because depending on the socioeconomic context will depend on what stresses show up for this kid and what stresses show up in the family. And certainly in that context, these little guys who were living in informal settlements or living in homes where there were 3 or 4 families, where they were noisy, they were loud, they were running in and out, where they were bashing into paraffin stoves, not managing this ADHD was a real risk for this child. Not because he couldn't get his A's and he couldn't get into some fancy program, but because actually people would get the hellion and he'd get a smack, or he'd get ostracized, or mom would get chucked out of the shack. Okay, so it's important in the context of all of this to just bear in mind what the impact is, and we'll discuss that in a bit more detail. So impulsivity, they blurt out, they interrupt, they intrude, they're quite demanding, and they'll get up into your space and they'll, but mommy, but mommy. And I say, just hang on a minute, we just go, but you know, and so they really struggle to delay their impulses. And many of the most impulsive kids will go through and really get themselves into risky situations. How does this look as you get older? I'll show you in a minute. Right, so let's just touch briefly on what it looks like differently. So we expect preschoolers not to sit and play for ages, but what's typical in these little guys, and why we as sort of specialists working with children have lots of toys and stuff in our room, because you can see what they do. They take, they move, they take, they move. It's hard to sustain a play activity. You can imagine if you can't do the game, okay? If you can't do the game in the schoolyard, it's going to be hard to sustain friends. It really is. Leaving activities undone, doing the finger painting, doing the little sticking on the paper, what have you, not listening. Those are things that are quite typical. And I must say, one of the saddest things that my son's ever said to me was, he's been at his preschool for 3 years. He said, you know, in 3 years, no one's ever asked me to sit in their birthday ring. And the reason being is because why? Because when everyone else is sitting around the dinosaur pit or the thing, we're like in here, and then we're there, and then we're there. So it does impact on the way a child can connect. And so, well-liked boy, everyone loves him, everyone knows him, but actually, because I can't sustain things, my connections actually are quite flimsy, okay? So the overactive child, easy to diagnose, but we'll talk a little bit about what else this might be. This is one of my biggest struggles, because I find particularly in the independent school setting, not so much in the government school setting, that the expectation of preschoolers is completely developmentally inappropriate. I don't think it's appropriate for 5 and 6-year-olds to get homework. I don't think it's appropriate for 5 and 6-year-olds to spend protracted times of the day at a desk. And there certainly is, in many of the independent schools, a really inappropriate developmental expectation of what kids of this age should manage. The other thing is the spectrum is so broad as to what's normal and what's not. So you'll have these smart little girls who'll be sitting there doing their little drawing, and then others who are rolling and rolling around the mat, and actually all of them are normal. So it gets really tricky in this, but there's been a lot of work done, and there's studies done on ADHD in underage kids. Don't listen, and they just like a bull in a china shop. What's also difficult, which I haven't listed here in these kids, is they tend to be very temperamentally reactive. So they react with big emotions very quickly. They react with big emotions, so they can be seen as quite temperamental. Their emotions are intense. They come up fast. They go down fast. The other thing which one doesn't see in the textbooks often is the development of the internal conversation and the internal listening to the body. So these little guys often have a hard time toilet training, not because they can't just stay on the potty, but also because that connection between what my body is saying and how my brain's understanding it is also quite immature, okay? So parents will often say to you, oh, he gets so busy playing, he wets his pants, you know. And it's actually true, because we're not feeling that distended bladder, we're not feeling the discomfort, we're completely into things, and then we end up having accidents. So some of this kind of stuff one has to take on specifically. All right. Primary school, again, forgetful, disorganized, distracted, restlessness, okay? Restlessness, need to move, get up, walk around. As I said earlier, often they can't manage their personal space. Often they interrupt, they blurt out. These kids, and there's often an understanding or a mistaken understanding from parents that if you've got ADHD, you must be deaf. You know, you must have a learning disorder, and it's not the case. So often they're very clever kids, and so they blurt out. They get in people's faces, and it can get very frustrating for teachers and peers alike. What's also not in this table is the issue around sleep. And I think sleep's very important, and I'll discuss it a little bit more. But these children are notoriously bad sleepers, okay? Notoriously bad sleepers. They struggle to get to sleep. They struggle to settle their little bodies down. And we'll talk about some of the co-occurring stuff, but they struggle to sleep. So they oftentimes, the ADHD circadian clock is pushed out. So if we could have bedtime at 9 o'clock or 10 o'clock and we start school at 9 o'clock, that would be great for the ADHD kid, but we don't. And so to compound some of these difficulties, often kids are sleep deprived, okay? And so then that adds to the confusion. Right, adolescents, so a lot of people say, well, as you get older, it disappears. And I think what happens is the executive functioning, the brain starts to develop, and just developmentally, from a developmentally normal perspective, kids just learn to manage, okay? Some of these kids just sort of but slapdash with what they do. They'll do what they need to do, and that's kind of it. They often experience this restless, fidgety. They don't specifically need to get up and walk, but when you ask them, they feel uncomfortable. They feel like they need to move. The impulsivity aspect of it is very potentially problematic. And what you'll always hear is, this one went on Ritalin, this one went on Concerta, became a drug addict. And what we know, without any shadow of a doubt, is that it's the untreated ADHD, the untreated, unmanaged impulsivity that results in bad choices, reckless behavior, and that's where the problem comes in, not because of the stimulant medication, okay? So these kids are very vulnerable, and they're vulnerable at getting quite depressed, and they're vulnerable because of their comorbidities. Adulthood, we're understanding more and more that that ADHD does indeed persist, that you don't turn 18 and turn off your switch. And I remember many years ago, Professor Holford and Smith doing a talk for the adult psychiatrists at WITS to say, well, these are the conditions that don't switch off when you turn 18, and ADHD, autistic spectrum disorder, those kinds of things don't just switch off. So we know that this persists, and there's more and more work being done. And again, the ADHD can work significantly in the child's favor, the adult's favor, but also often results in occupational difficulties. And so this is just said in another way, lots of behavioral issues, and here, this for me is quite key. This starts to happen, self-esteem issues. And what does this present a risk for? This presents a risk for depression, this presents a risk for anxiety, and this presents a risk for an internal conversation that becomes quite negative. And interestingly, this is often my selling point for medication. So we tick all the boxes, and they say, well, so what? And it's true. So you tick all the boxes, well, so what? But what is the impact here? What is the impact? Social interactions, what's the conversation that this young person is having? Say, I'm bad, I'm naughty, I can't think, I'm deaf, I can't do my work, no one wants to be my friend. Okay, so this is a very squiggly thing, just to show you, just another way of talking through what I've spoken about. This whole green part here, we're going to unpack in a little bit more detail, because I think you're all familiar with all of this, and we can tick all the boxes and all of that, but a lot of the stuff that really impacts is the so-called executive functioning. And there was a lovely video that I couldn't download, but I'll leave the slides with Amber. If you look at that, Russell Barkley is a well-known scholar in ADHD. There's these lovely little 3-minute sound bites where he explains this kind of stuff, and I couldn't embed it into the slide, I'm sorry, but we'll go into that. So the executive functioning, and Russell Barkley sort of feels, well, this is quite core, that it's not just about concentration, hyperactive, and impulsivity. It's about the executive functioning, and it's about the frontal lobe. And when the frontal lobe and the connections to the frontal lobe aren't working adequately, this is all the stuff that starts to happen. You start to have difficulties with laying down memory. You struggle to manage your emotions and to modulate them. And this is the chart that I actually show parents. I run them through the tick list, and they go, yes, 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 yes. And I say, well, and here's the real issue. Can't manage our emotions. Can't get to sleep. Can't persevere. Unless we're guaranteed of success. We'll start out, right, 3 lines ago, it's too hard. Okay? And leave it. So perseverance, processing speed, sustaining focus. So sustaining and persevering, quite a key issue. And getting organized. Streamlining, prioritizing, planning ahead, knowing what comes first, what comes next, and self-regulation. Okay, so this is quite key. This is quite key, and this doesn't just fit neatly into the checklist. So what Russell Barkley says is executive functioning helps us achieve a goal. All right, it takes us from A to B. Okay, it involves problem solving, and it involves goal-directed persistence, and this is where kids really, really struggle. So it helps us put the brakes on so that when we're actually standing in that queue at Checkers and you've only got a loaf of bread, you don't just say, what the heck, take your bread and walk out, okay? Because most of us have thought about that. But it helps to put the brakes on. And sometimes you can say to parents, the brakes are off. The brakes are off. I'm not taking things in adequately visually, okay? My son's visual working memory is spectacularly poor. He'll be saying, where is it, where is it, where is it? And he's standing on it. Okay, so the visual working memory, the non-verbal working memory is quite poor. The verbal memory working memory is quite poor. And that conversation in your mind that says, right, okay, I'm coming out to Novartis today. I need to think about the fact that it's raining. I've got to drop off by this time. Doesn't happen. Okay, and then we've discussed this emotional and motivational control, problems to plan. So understanding the impact, and I put this up, and I know it's quite funny, but it also makes me cross, because there is this stigma around these poor kids, and actually, you know, they're just like any other kids, but the reality is that people think, this child has ADHD, there must be something wrong with them. And so it results in a whole lot of struggles for these kids. And for me, the poor self-esteem, the risk for comorbidity, the parental frustration, because this can be really damaging in terms of relationships. The academic failure is usually what brings them into the office, the social difficulties, but actually when you really unpack it, you can see that these kids have a tough time. All right, so this is, I need to walk closer because I can't read. But it really outlines for me a couple of areas where the functional impact comes in. So the sporting impact, the dancing impact, how are you managing the ballet? What's he like on the cricket field? Is he managing to get through on the team, or is he sort of counting the birds when the cricket ball comes flying into the outfield? Okay, is he the goalie because he just sort of stands there? And you know, so all of these things impact functionally, and they impact on the day-to-day. Is he annoying his mates? All right, and home. And I think we can't underestimate this. Parental stress, parental emotional and mental health problems. And remember that most of these parents have ADHD themselves. Okay? Most of these parents say, but look, I was fine. Yeah, I was fine. And yeah, sibling conflict, because they drive the kids nuts. I've got one little boy. He's the youngest of 4. He's the most delightful, beautiful, lovely, lovely child. He's clever. His father's a lawyer. His father, I've said to his father, I don't know why they still come back. 3 years, his father comes into my office every time, and he tells me what a little SHIT he is, because why? He sits on his knees, and he disrupts the mealtime, and he does this, and he does this, and he does that, and he must get it together. And actually all he's doing is very, very normal 10-year-old ADHD stuff, okay? But it causes big issues for this father. I know Dr. Helen Clark also says she used to love when that Woolworths queue with the sweets, and she would say, right, who, you, depending on how the children were handling being in that queue with all the temptations. This is also an important thing, less time available to spend on family activities. And what we're going to go into in a little bit of detail now is the fact that there's a lot of comorbidity. So it means a lot of remedial work, OT. What should have taken 20 minutes of homework is now taking an hour and a half. You know, so this really impacts on the family. So it really feels, and when parents get to accepting treatment, they get to understanding how their treatment can impact on the rest of the family, and things soften. All right, so untangling it all. Right. This is the question. So, concentration problem, naughty child, what else could it be? It could just be the developmental stage, could be an emotional issue, a behavior disorder, learning difficulties, what I've called physical problems, and other medication. Anxiety and ADHD, for me, are sometimes impossible to separate. And I remember when we were training, and we used to have to go and take our cases to Professor Holford once a week and present the case. And then you'd wait and she'd say, have I taught you nothing? This child has ADHD. And then next week you go with your case and she'd say, have I taught you nothing? This child has anxiety. And I have to say that still, and I still go to her for supervision, there's some times where I'm not sure. And you have to just hang your hat on a hook and go for it. And know that you might be wrong. So these kids, restless, fidgety, don't concentrate, lots and lots of background noise. Traumatized kids in particular, their concentration goes in and out. They're there, they're not, they're in their heads, they're all over the place. Depressed kids can be very irritable, very restless, very emotionally reactive. Okay. Parental conflict, huge issue. Kids who are living in stress environments can look like a cat on a hot tin roof. They can look completely restless and agitated. What's complicated about all of this is, of course, all of this can coexist with ADHD. So not only is this the differential to say, well, is this ADHD or is this anxiety? Is this ADHD or is this a reactive attachment disorder? Okay? Because this little kid, he comes to check us and then he sees some auntie over there and he's like, off he goes. How's it, auntie? How are you? My name's so-and-so. Is that an attachment disorder or is it disinhibition from ADHD? Okay? And of course, kids with attachment disorders have very high rates of ADHD. Behavior disorders, conduct disorder, I just won't listen, I just won't do. Oppositional defiant disorder, I'm irritable, I fight with my peers, I blame them for things that I've done. Common comorbid conditions, but could it be just a behavior disorder or just parenting problems? Parenting problems goes in the basket with all of this, okay? My favorite question became, so what dose are you taking? What dose of Ritalin is your child on? Oh, I don't know. What dose are you taking? What time are you taking it? Okay, of the 7-year-olds. So then you can imagine what's happening to the diet, what's happening to the sleep and the routine, and who's doing the homework, because the 7-year-old's taking his own Ritalin. Okay? Physical concerns. And for me, these are quite big issues. And I spend a lot of time trying to work this out. Sensory integration disorders. Sensory integration disorders are very common in kids with ADHD, and they look like ADHD. Kids who have proprioception difficulties, with proprioception being your sense of your body in space, sort of knowing that I've got about a foot between me and this table, knowing that, I've got to watch out for my coffee cup behind me. Kids who don't have a sense of that will move, they'll bash, they'll be all over the place, okay? And sometimes it's not ADHD. Sometimes it's just about getting some OT. Absence seizures, which I think everyone knows about, and complex partial seizures, these are forms of epilepsy where kids clock out, behave in peculiar ways, or are just absent. Sleep deprivation is a big issue, big issue. And it happens in kids with ADHD, but it also kids who aren't sleeping well look like they have ADHD. I've had a handful of children where we've sent them for sleep studies, kids with big tummies who have obstructive sleep apnea, okay? And they're not sleeping properly, so they look like they've got ADHD. Low motor tone, poor core body strength, wriggle, squirm, flop, lie all over the place. Severe ENT issues. I remember a consultant when I was a student saying, do you want to watch me cure mental retardation and treat sinusitis? And all of a sudden the child who looks deaf and can't think and can't breathe suddenly brightens up, and there's his cure for mental retardation. But I've seen these children referred for severe ADHD. They come into the room, you can hear them breathing the minute they walk in the door. You send them to the ENT, no need for medication from my side. Hearing and visual difficulties, and then other chronic illnesses. And I've got a handful of these very early onset diabetes, which impacts on behavior and wellness, but also co-occurs. Learning difficulties and intellectual impairment. And then medications. This one is an interesting batch because these medications, the epilems, the lamictins, and the old-fashioned phenobarbs and all of that cause a lot of behavioral activation, what Professor Holford calls behavioral toxicity. Okay? And so you've got kids on epilepsy medication who are as mild as anything, and they send them to you for treatment, and actually it's the medication. And I had one of those recently, actually. All right, so we've got to work this out. What else could it be? Or is it just coexisting? Other factors that we've alluded to that could impact on a child looking like they have ADHD. And then these, of course, are the co-occurring conditions. Anxiety and the behavior disorders pretty much co-occur 50% of the time. Depression comes in later in about 25% rates, and depression obviously is a risk in adolescence. The learning disorders are very common. Tic disorder is less common, around about 8%. Tourette's itself around about 2%. The SI problems, I don't know what the rates are, but my day-to-day experience is almost that it's ubiquitous. It's almost like if you've got SI issues, you've got ADHD. The sensory integration. So sensory integration is, it's all, there's 7 senses: touch, taste, smell, sight, sound, proprioception, and vestibular, which is the movement sense. So either kids are over-responding or under-responding to their experience of sensations. Okay. So when they over-respond, or let's say, for example, they're under-responding to proprioception, they're not aware of what's around them, then they bang and bash. Okay? If they're sound sensitive, they can't tolerate too much noise. Paradoxically, they make a lot of noise. Mm-hmm. Okay? That kid who's all the time often is the child who's auditory sensitive. Tactile sensitivity, they don't tolerate particular feelings, particular fabrics. So those are the SI problems. And then autistic spectrum disorder. So the old classifications didn't allow us to make both diagnoses, but now we can. Okay? And this co-occurs quite a lot. And the substance misuse really comes in down the line if these conditions are unmanaged. Okay? It's not ADHD or stimulant medication that causes substance abuse. So this is just this said in another way. The coordination problems are interesting. So many, if not most of my patients start life out at 2 with some physiotherapy because they're sitting floppy or they can't pull on jungle gyms, and the northern suburbs mommies realize that. Okay? They can't do sports, they avoid swimming, that sort of stuff. Very common. Okay, and you can see here the gamut of things. So we've spoken a little bit about the sleep problems, low self-esteem, doing poorly academically. And in the community that I serve, that's a big issue. So the common mantra will come in to say, well, he's not achieving his potential. Okay? He's getting 70%, but the teacher says he's not achieving his potential. Well, he's getting 65%, not achieving his potential. And it is true. It is true. You can do a psychoeducational evaluation of a child with ADHD, and those scores are all over the place, and you give the Ritalin and the scores just can do that. They're just kind of in line. It's quite remarkable in some kids. Social difficulties and relationship failure, and then we've spoken a lot about the thing. So often what I do at the end of my consultation, because there's inevitably comorbidity, and I've tried to simplify this, but it's very seldom this simple, is say, right, I think we've got this, this, and this. And this is how they relate to each other. The ADHD, will cause your child to have some anxiety. Why? Because he is cognizant that he's not keeping up. Okay. His anxiety will cause his concentration to get worse, will cause him to move a lot more, and it will make his ADHD look a lot worse. I mean, these are the kind of things. I'm not... your child has sensory integration problems. When your child gets anxious, his sensory integration problems get a lot worse. When your child's sensory integration problems get a lot worse, his ADHD looks a lot worse. Okay? And so one can go around and around in circles, and you can draw squares and triangles and pentagrams or whatever the case may be. But what we try and do is help the parent understand that it's not just about this, but that all of this is making an impact. And actually we need to look, and you try and separate it out individually, but you can't. And you try and say, right, this is how we need to tackle this, okay? This is how we're going to approach the management. Okay, we're nearly there. Right, so, did you get it? Okay. And I must say, I think this is very common. So making the diagnosis, as you all know, is really a clinical diagnosis. It's a clinical diagnosis. We've got some tools to help us. We talk a lot to people, and with the course of time, one gets a feel for these things. And so this is a bit detail heavy, but really you've got to observe, you've got to look longitudinally, you've got to look for risk factors, you've got to exclude what could be, what was, what might be, and all the while you've got to make sure that you hear the parent's particular narrative around what this means for them and their child. I've had parents, one at Child and Family Unit at Johannesburg Hospital, when we sat to give her the feedback, she bolted out of her chair, ran out the office and down the passage because we told her child had ADHD. And then when we looked back, she herself had ADHD, and she had a particular stigma and a particular negative experience around the ADHD. Okay. The teacher's input is very important. But again, like I said, my personal view is to just take it with a bit of salt, because I just feel like there is an expectation in certain learning environments that we want little compliant robots. And I have a problem with that. Okay. So the standardized questionnaires, we use a lot of Connors, we use a lot of Copeland's. I have a little teacher's report which I copied from the Child and Family Unit. And we put that together, and then reports from OTs, speech and language therapists, educational psychologists. There's certain things that we can sort of cobble together that to see, is there a common thread going through here? What's each of these professionals' experience of this child? And then this for me is important. Clinically significant impairment, okay? Is this child functioning in his or her role, expected role function? So how is she managing in the family? What's happening in the learning environment? What's happening with her relationships? Is she getting any physical development? Is she participating in physical activity? What's happening to her physical health? Tummy aches, headaches, constipation, not eating. Where is the impact here? And my personal view, and I suppose this is why I've got this reputation of being a conservative prescriber, is that there must be impact. We're not here to medicate parents' aspirations or teachers' inappropriate expectations. We're here to say, well, this is a little person. What's happening to the development of this little person because of this condition? And do we have to put a neurochemical in the mix here, or is there something else we can do in the meantime? Okay. Okay, so we use the DSM criteria, we use the rating scales, and then the neuropsychological test. The WIPSI is one for under sixes, and the WISC is the one we use in the independent schools, or the SIS in the government schools. All right. I just wanted to mention before making the diagnosis that obviously, as you're aware, DSM-5 has changed somewhat. What's nice about it now is that they've made the age for diagnosis a little bit later. And I think it's useful because previously it had to be before the age of 7, and I think there's too much developmental variation before the age of 7. I think it's too difficult in grade 1 or 2 to work out what impact this condition is having. Okay, and a lower threshold of symptoms for adults and adolescents, so meaning that you need fewer symptoms on those checklists to make a diagnosis, because we understand that adult and adolescent behavior is different. Okay, and this is quite a typical scenario for an adolescent with ADHD. All right, management matters. Okay, and I put the emphasis on the matters as opposed to this just being management matters. Management matters, and you have to think about, what are we doing here? What do we want to get right here? What do we need to alleviate? What do we need to address here? So it has to be managed in context. Sometimes you have to refer parents. Sometimes you have to parents need to go on their own medication. And I had a very glamorous family that I saw. They've recently moved back to Mexico, but a very glamorous Mexican family who I saw the parents for 3 consultations before they took medication. They came back, and they came back, and they came back. They wanted to discuss, they wanted to understand, even though mom's father was clearly ADHD, even though dad was clearly ADHD and had a conduct disorder and never finished school, but he's a high-flying businessman. So eventually, after 3 consultations, they said, right, we're going to put our little precious girl on some Ritalin, and they did. And Dad thought, well, I need to know what my child's experiencing. He took the Ritalin and he said, oh my goodness, okay, 40-something. I can't believe I've been living like this. So we sent him to see Dr. Liebenberg, and he's been happily on treatment for 3 years. Yeah, never looked back. So sometimes one has to do that, and I've sent more than enough parents to Dr. Liebenberg to go and get treatment for their ADHD. Alternatives are a big issue. I won't get into that. So goal setting, you need to set a goal. You need to be quite particular, because parents will have particular, now you give him the Ritalin, now everything's fine. But I got home from work and he's performing and he's running up and down and he's chasing his sister. Your medication is complete rubbish. Okay? The non-pharmacologicals are as important. I don't believe that there's any evidence for diet, but there is certainly a lot of merit in eating well, making sure the child exercises, making sure that the child gets enough sleep. Okay, psychoeducation, I think, is key, because if people understand what to expect, what not to expect, and what you're doing, I think it makes a huge difference. We don't do as much of this behavioral therapy in the private sector as what we did in the public sector. And some of the studies on the under 6 ADHD actually made sure that parents, before they came onto medication trials, had been through a year's worth of behavioral therapy and training, teaching parents how to manage a suspected to be ADHD child. So there certainly is some evidence for structure, routine, responding in particular ways. And we help parents to put up visual cues for kids, to put up behavior charts, star charts, reward systems, all of that kind of stuff can be very, very useful. Okay. Often for me done in conjunction with the medication, because when the medication's there, everything settles down, and then everybody finds it much easier to manage. Okay. I don't want to spend too much time on this. This is important for me because if you've got an educator who's on board, he or she can direct the child's behavior positively, where you can say, you know what, just take an envelope, close it up, send him to the office just to give the envelope, just so he can get out and walk. Or just send him for a little tumble down the passage, go and do some flip-flops or, somersaults, come back. Okay? And obviously rewarding positive behavior is very useful. And then of course the big controversy. And look, for me and my personal experience is that this is a life changer. And I think for many kids and families it is a life changer. I've spent a lot of time recently, again with a colleague. She's a social worker at a very big independent school in Joburg. Her son is in grade 1, grade 2, grade 1. Also, 2-3 meetings discussing, but yeah. And eventually I just said to her, you know what? I went to see Dr. Kelly. This was what we've done, and it was not a big deal. It really wasn't a big deal. You take the medication, and that's it. Yes, you deal with the appetite issues, and you deal with the weepiness coming off, but actually, it was not a big deal. And I saw them the end of last week, and she was quite tearful almost, and saying, like, she actually can't believe it. She cannot believe that they fussed so much. And actually, all she did was went on some LA10, and there you go. It's hard to get people to accept that, okay? But it really is an incredibly useful. This is the take home for me. I don't want to talk to you about stimulants today. I don't think you need to be spoken to about stimulants. Is to make sure that you address all of this, that you make sure that you're cognizant of all the issues that the patient will present with. Make sure you look for that obstructive sleep apnea. Make sure you manage that anxiety. Make sure you send them to the OT. And then those are some of the medications. These are the things that the OTs say, give them a bad name. Supposedly, manage your ADHD with your fidget spinner. Okay? Manage your ADHD with your fidget cube. Thankfully, all been banned from most classrooms now. So, yeah, these aren't treatments. You know, I'm sure you've encountered all of them. This is an interesting slide that I just want to finish off, because I've spent 10 years quoting the MTA study, and when I went back to read it again, I saw that there's something very interesting here. So this was a big study done in the early 2000s in America, where they followed up about 600 kids who'd been started on Ritalin at around age 7. They followed them up after 2 years, and pretty much they followed them up for a subsequent 8 years. Okay. What was interesting for me is that, without any shadow of a doubt, initiation of treatment marked improvement in the first 2 years. But as we got further and further away, and as we grew up, it's sort of the kids who'd taken treatment and the kids who didn't take treatment sort of coalesced, and there wasn't that much difference. So it does ask a big question about what's the role of medication beyond that initiation. I mean, I can only talk subjectively from the perspective of my patients, many of whom are at university, many of whom swear by their stimulants, many of whom will not give their stimulants up, some of whom have developed tics and will still not give their stimulants up. So, you know, it just begs the question. Good treatment response is not just about the pills, okay? It's about helping a person manage and adapt, and really severity and all of this other stuff is going to impact what the outcome is. So we know it's a chronic disorder. We're not sure how much it persists, but between 40 and 60% of adults. And they're a particular cohort, obviously, in which things are persistent. And I think I probably kept you longer than I was meant to, but thank you, and yeah.